on to depression. Oh, okay. So I don't have anything to disclose. You know, I wish I had some big drug company sponsoring me for lots of money, but I don't have much at all. Hawaii State Rural Health Association and some grants. That's about it. So unfortunately, no big money coming in anywhere. So, oh, okay. We're jumping right into depression, I tell you. No rest for the weary here. But you guys all know this, so it's not new for you, but of course, it's always good to remember. When I learned a mnemonic for depression symptoms, it was SIG ECAPS: sleep, interest in things, feelings of guilt, low energy, poor concentration, either increased or decreased appetite, depressed psychomotor, so less movement, and then suicide or substances or psychosomatic, I think, but that'd be a P. So that was the mnemonic that we used, but of course, all these things are signs of depression. So the loss of interest in the things that you usually do, the activities and relationships you have, feelings of sadness, hopelessness, emptiness, sex, less interest in sex, either sleeping too much or not enough, just like eating, either eating too much or not enough, something really changing from your normal. Emotional outbursts to anything more than usual. So some change from normal. Physical or mental just exhaustion. And oftentimes that's, you know, you say you're too tired to do what you normally do or meet with who you normally meet with. So then there's the anxiety, increased anxiety, getting agitated or restless, not feeling comfortable, feelings of worthlessness, so low self-esteem, memory loss sometimes, although we all worry when that happens that we're getting some cognitive decline, inability to think straight. So that's something that people also worry about cognitive decline with, but it's something to notice. And then thinking about our failures or past events or things we just can't really get over. And then chronic pain feelings, unhappiness, feeling numb to everything or to most things or to anything, you know, feeling numb. I just don't feel anything anymore. I don't care anymore. And then of course, suicide attempts or thoughts is our biggest risk and our biggest fear with depression. So you guys know this. Here's our PHQ-2 and our PHQ-9. So the PHQ-2, oh, let's see here. So, oops, sorry. So the PHQ-2, in the last 2 weeks, have you lost interest or pleasure in doing things? 1 to 3, go up higher. Is it just 1 to 3? I guess they're both just 1 to 3. And then feeling down, depressed, or hopeless, 1 to 3. And then the score is, of course, 0 to 6. So 3 is the cutoff. If it's 3 or greater, then you're worried about major depression. But I would say if you get anything on the PHQ-2, you're going to want to go to the PHQ-9. And some people just jump to the PHQ-9 anyway. So this is also in the last 2 weeks. Loss of interest or pleasure in things, feeling down, depressed, or hopeless, sleep changes, feeling tired or low energy, appetite changes, feeling bad about yourself, failure, guilt, ruminating on past things, trouble concentrating, like reading a newspaper or watching television, and then moving slowly, moving or speaking so slowly that other people have noticed. So people have said something about it. And then thoughts that you would be better off dead or wanting to hurt yourself or commit suicide. So that's the PHQ-9, which you guys know about well. So this is divided up on breaks of 5. So 0 to 4, don't have to worry about. 5 to 9, mild depression symptoms. So you want to repeat it in 1 to 2 weeks. 10 to 14, moderate. So you could talk about counseling. You could talk about pharmacotherapy. I don't know, I'm more conservative and I think everybody should have a therapist. So I don't hesitate to recommend a therapist for folks, but some people really don't want one. And then the second generation antidepressants are very, very safe in adults. So I have a low threshold for doing that as well. But some people will point out, and then you're just masking the symptoms, you're kind of hiding it. You're doing what doctors do and overtreat. Guilty. But if you're 15 to 19, you probably do want to start therapy with either, I would say both, but then I'm conservative there. And then 20 to 27, definitely both. I would probably have very frequent follow-up. I would probably consult a psychiatrist at that point for some collaborative management. Interrupt me if you want to anytime. You can correct me if you want. I just wrote this up yesterday, so I won't take offense to anything. Oh, I wanted to touch on suicide because I heard a good speaker last week at the Kauai Drug Summit, and I had never really thought about talking about suicide this way, but I've always asked the question because, the other question on the PHQ-9 is that question at the end, of course. If they say yes to the suicide question, that changes your whole day around because you've got to get them into some help, of course. And so that all by itself is a significant question. And up here is the National Suicide Prevention Hotline, which you can call and say, what do I do? And I learned yesterday that you can just text in hello in your cell phone, and that should be the National Suicide Prevention Hotline too. And then I also heard her say, which I hadn't really thought about before, but suicide is like throwing a pebble into a calm body of water because it sends out ripples in so many directions. It never just impacts the person who commits suicide. It impacts everybody around them. And sometimes people don't think about that. I mean, I know I've had thoughts of how awful everything is and how much better it would be. Now that was my ding, sorry. Let me turn this up. How much everything would be better if I weren't here. But of course, that's very subjective and very self-serving to think nobody else would be affected. And then I remember when I was young thinking, oh, well, if I died, I'd make my dad upset because he was my main parent at that time. So, people think different things. And what's important is that we recognize it. And I heard a wonderful story last week about the speaker's son who she talked to about suicide. He said one day he couldn't do what he wanted. So he said something like, I'd be better off if everybody'd be better off if I was dead, and slammed his door. And she went to talk to him and she said, did you really mean that? Because that's worrisome, because if you were to do something like that, it would affect everybody around you and everybody in the community. And I want to talk about it. And so she said she had a short talk with him about it. She talked with him about the symptoms, what they look like. And I know this is covered in youth mental health first aid. And so that's a good thing for people to take because she just talked to him about how when somebody's planning suicide, they tend to withdraw from people. They say goodbye. They might give their valuables away to people in preparation. They might take risks you wouldn't normally see them take. They might show signs of depression, like eating or sleeping more or less, showing mood swings, taking drugs or alcohol more often. And they'll tell you, if you ask, they'll often tell you that they're feeling hopeless and have no reason to live, that they're really sad, that their emotions are just overwhelming. And that's when you want to ask them. And so this is something I learned too, because as a physician, I was taught to say, are you thinking of harming yourself or others as a screening tool? But she said, you have to say suicide. Otherwise, they might think they're not harming themselves if they take that whole bottle of medicines. That there's no harm, they're just going to go to sleep and not wake up. So she said, you have to ask, actually, are you thinking about committing suicide? And so that's something I learned last week. And so her son went on to actually save a couple lives, because both in his senior year of high school and when he was in college, he noticed students having these symptoms. And this is even more pertinent now, because I learned a friend of the family who was 21 just committed suicide recently. And so, you know, I'm just putting this out there. We all know this, but just remember to talk to people about it. And my office does offer free youth mental health first aid training. It's been a few years since we've done it because of the pandemic, so we're happy to start doing it again. Okay, enough on suicide. So the American Psychological Association just did this publication. I think it was 2019. What does it say there? I think it was 2019. And so I thought it was a good kind of description of what to do for different age groups. So in adolescence, oh, sorry, the 12 and the 13 are references, so if you can ignore those. So what they offer, or what they recommend, is cognitive behavioral therapy, interpersonal psychotherapy adapted for adolescents. And then if you're going to use a med, fluoxetine is the first line. And then paroxetine looked like it was the second line. Now we all know there's a black box warning. I believe it's a black box warning, but I have not heard of any suicides with adolescents starting SSRIs. So that's the good news, but there is a black box warning because teens may be more likely to express that, think about suicide. So we have to watch them really carefully. Remember, interrupt me anytime, because you guys probably know this better than I do. Okay, so for adults, either psychotherapy or second generation antidepressants. And the types of psychotherapy they had strong evidence for was behavioral, cognitive behavioral, mindfulness-based cognitive therapy, interpersonal psychotherapy, psychodynamic therapies, and supportive therapies. So a lot of therapies there, but they didn't list all of them. There were some that didn't have enough evidence to put them on this list. And then if you want combined treatment, which I say I recommend for everybody, cognitive behavioral or interpersonal and a second generation antidepressant. And you know, all this is made in shared decision-making with the patient. So that means talking a lot with the patient and seeing what they want, because some people say if I go to a therapist, it'll impact my career, people will find out, I'll be blackballed. Some people say, I don't want to get on a medicine that I'll have trouble getting off of. So, but you guys know we should, if it's major depression, we should have people stay on the medication for at least a year. So that's part of the shared decision-making. I am willing to put you on a medication, but I'm going to recommend if you start it, you stay on it for a year, even if you feel perfect, because studies have shown it's more effective longer if you stay on it for a year. So they might not want a medicine for a year. It might cost a lot of money. Most of them are generic. Well, the older ones are generic. So it shouldn't cost a lot of money, but you don't know what people, you know, maybe they know they're going to lose their insurance or something. So talking to them about the pros and cons. Now, this document did talk about alternative integrative therapies. And they said exercise monotherapy, which I didn't understand because you can put exercise with everything and it's going to make you feel better after you do it probably, or during, sometimes during while you do it. So exercise I think is good for everybody. And then St. John's wort as monotherapy, of course, can interact with a lot of medications. So we want to be very careful with St. John's wort. But also adding in yoga, bright light therapy, and acupuncture were three that have evidence behind them that they can help as additions. So there are those. And then for kids, what they found had evidence was life review treatment, which I haven't heard of in Hawaii, or group cognitive behavioral therapy, either alone or added to usual care. And then combined pharmacotherapy and interpersonal therapy was recommended. They recommend second generation antidepressants. Oh, sorry, I said youth. This is seniors. Nortriptyline has been used in a lot of studies and been found fairly safe, but the side effects may make, let's see, I think you get dry mouth, you can get unstable, which of course are problems in seniors. Sleepy, which is good for some people, but then if you're sleepy all day, that's not good. So some of the side effects are undesirable. And of course, there are drug interactions, so you have to be careful with that. So probably a second generation antidepressant. And I'm not going to go into which ones are more sedating and which ones are more activating and stuff like that. But there are some that make you eat more. There's some that make you sleep more. And so it would be, again, discussion with the patient. Oh, which kind do you think you want to do? So let's see here. I'm just going to admit folks and get back to it. Okay, so new stuffs. And I'm glad Dr. Alicata is on because I could be way off on all this. I just Googled and looked up new articles to see what might be out there in the future coming for depression. So correct me if I'm wrong, everybody, because I just kind of looked this up. So what this says is there aren't really any new adolescent therapies for in depression. This article was last year and said there are no new leads in the prevention and early intervention of depression in kids and adolescents. For acute treatment of major depressive disorders, they're doing a lot more internet-based therapies, which of course is good in that age group because they are more, device-centric. Family therapy may have a slight edge over individual psychotherapy, depending on the family, depending on if there are any abusive situations. You don't want to have that in the therapy room. And then severe depression with endogenous features have more robust response to medications than patients with mild to moderate depression. And then, the brain-derived neurotrophic factor levels, which have been researched in depression, are different in kids than in adults. So I thought that was interesting, but I don't fully understand it. But things are heating up in this area, so let's just not apply everything that we do with adults to kids. But one thing we could apply might be ketamine if treatment refractory. So the brain-derived neurotrophic factor is one of the neurotrophic factors that support when the cells are regenerating, differentiating, maturing. It helps protect them. I'm not really good on the brain-derived neurotrophic factor, but it's one of those things that helps with your regeneration, keeping it clean and not deviated from what it should be, is my understanding. Oh dear, Verizon service. Sorry about that, Renata. So ketamine, there's two kinds of ketamine. We've heard about ketamine before, and so I'm not going to go into depth on this. I'll just tell you that the nasal spray, I only found 4 providers in Hawaii that actually do this, and one of them is at Tripler. So really that's 3 providers for us. I hate to think how much it costs, but it uses only one of the molecules in instead of both the reverse and the S molecules. So I don't know. I haven't given it out. I'm not a provider. So Dan or anybody, have you had success with the nasal spray? Oh, Renata read. Oh, sorry, Dan.
No, I didn't want to interrupt. Kelley, yeah, so thank you for bringing this up. And it reminds me that we need an update from Dr. Liu on ketamine. So I will reach out to him because I know that he's using it quite a bit at Queen's Counseling Services.
Yeah, does he do it for chronic pain at all?
And that I don't know. So I think we really do need an update from Dr. Liu. And just a comment on your brain-derived neurotrophic factor. Really interesting data on levels increasing even with psychotherapies. We've historically known that antidepressant medication has always helped, but in adults where they're using transcranial magnetic stimulation, significant increases in brain-derived neurotrophic factor in the healing process. And I think we're seeing from FDA some new indications in the near future because they've been sponsoring a number of pilot programs for children in refractory anxiety and depression. We'll see the indication for transcranial magnetic stimulation for children probably very soon. So we're very hopeful in that. So that also reminds me, I'll follow up with Dr. Ona to see if we can have updates with TMS.
Yes, and I'm going to want you to tell her about one of the things that I found online in Hawaii coming up. But anyway, more and more people are doing IV ketamine, but it's not really listed anywhere. You can't really find it, but it's becoming more and more popular. But what it did say online is it can cost between $350 to $650 a session, and you're supposed to do 6 to 8 sessions over 2 to 3 weeks to see if it's going to work. And then if that doesn't work, you stay on to something else. But then you would do it like every couple weeks, and it takes about 40 minutes a session, I think. So it's a serious time and money deposit, contribution, but it can really work wonders. So it's something to think about. It's on the horizon, and my guess is more and more insurances are going to start paying for it once it's got a lot of evidence behind it. So keep that in mind. But the nasal spray, I'd love to hear more about because, it's easier. I think you would, well, we'll hear more about it. All right, this is interesting. Okay, so this is a clinic in Hawaii, and they call it MERT. They don't call it transcranial magnetic stimulation. And the only reason they don't call it that is because they do an EEG and an EKG or ECG, electrocardiogram, before they give it to you. Now, this will be good to ask Dr. Ono, because if you have an EEG and there are certain areas responding, I suppose, less, then, well, you don't have a baseline. So I'm just a little confused what they would look for. And I think you put the transmagnetic stimulation in the same place anyway, but maybe they move it around. I mean, it's kind of interesting, right? Oh, and Dr. Cohn is talking about mushroom therapy. Yes, that is on the horizon. I couldn't find anything about it. But next time we give this update, it'll probably be more mainstream. But yes, low dose of mushrooms has been working. Is ketamine a short-term reversible electroshock therapy? So no, the ketamine is infused and it is, or inhaled. So it's not shock or anything, but this transcranial magnetic stimulation is, I believe it's sound waves? No, it's magnetic force. It's magnetic stimulation, basically. So I think they're just changing the electron direction, basically. But we'll hear more from Dr. Ono. But Dan, what do you think about this? Would an EEG help you know where to put the thing? I don't know.
Yeah, great Great discussion. And Kelley, so lots of FDA investigation looking at the role of EEG in mapping not only the location, but the motor or the strength of the TMS that's needed to synchronize EEG. And so we all know that the electroencephalograph have been normalized or standardized with resting state fMRI. So there's a whole literature on using office-based EEG that kind of replicates what resting state functional magnetic resonance imaging does in the clinic. And so patients don't have to go into a research or a clinical fMRI machine. I mean, we have two machines at Queens, but it's a real significant challenge and it's very expensive. But EEG is what a lot of clinicians will just do in the office to look at the synchronization of brain activity and then use what you see here with MERT. And we have a couple of clinics here in Hawaii who are already doing it with adults and children. But the FDA indication is for adults right now, and we're hoping soon we'll see the indication for children in the near future. But again, it's using the EEG activity that tells you exactly what the what the brain synchronization and networking activity looks like, and then using the TMS machine to help in synchronization or synchronizing what is abnormal to what is normal. And again, what is abnormal normal has already been kind of given in guidelines based on functional resting state fMRI.
Interesting. And the mushrooms are the psilocybins. Did I say that right? They're the hallucinogenic mushrooms that they're trying in small doses. And they seem to be having some success with that. So more later on that. And I know we asked, when we had Dr. Ono last time, we asked her, well, what about these home tests, home kits, where you can have this electromagnetic stimulation at home? And so this one is FDA approved for depression. And they say people have some results in 2 weeks. It's also indicated for anxiety and insomnia. It costs $299. So you do it for 20 minutes every morning. So it's, I don't know, I didn't see the articles on it, but I thought it was interesting because we did have questions of whether it worked or not, because we saw the in-office ones, the big machines, and then this would be something at home. So more to ask Dr. Ono. Okay, and then we have talked about this genetic testing before. Oh, maybe we should have somebody come back and talk about this. It's been a while. So what this will tell you, and anybody correct me if I didn't get it all the way, it will tell you if you are more or less likely to, if you take a medication, do you burn it fast? Do you break it down really fast? Or do you not break it down? Because if you don't break it down, it's going to go way high and you're going to want to take less of it. But if you break it down really fast, it's not going to work, right? So if you're having trouble with somebody trying different medications and they don't work or they have side effects, this is a good idea because it'll tell what the person's genetics do about the different medications. Now, I haven't seen one of these reports, but it costs about $300. And I think insurance is starting to come around to it, especially if you've had a number of failures of different medications. Has anyone seen one of these reports and what it looks like? Well, if anyone does, I want to see it too. Okay, so this is kind of exciting, and I don't know much about it, but the inhibition of kinase enzyme CDK5. So CDK5 is something that breaks down the neurons and is bad for our brains and is found in higher levels with different neuronal breakdown with degenerative mental disorder, well, not mental, well, yes, mental too, but it's found in higher doses with dementia and things like that. So they just found something that is anti-CDK5 and gets through the brain. So they call it 25106. And before they had some of these anti-CDK5s, but it couldn't get through the blood-brain barrier. So now they have something that goes through the blood-brain barrier, and they've tested it in mice, and they say it's decreased anxiety. So I don't know, but we may be seeing something like this. So this is a phosphorylation enzyme. So it goes in and it phosphorylates things, probably to get them out of the way, or instead of repairing them to, I'm not sure. I'm not going to speak more on that because that's not my area of expertise, but I was excited to see that there might be something new on the horizon. Anybody know more about that? Oh, yes, we should be fixing the underlying causes with the psychotherapy, perhaps. Interesting you should say that, because I'm going to say something controversial here, but we're going to discuss it next. We're going to discuss gender identity things, but on, I wouldn't say he's my favorite comedian, but Bill Maher last week said, well, what if it's depression or underlying causes of confusion that make people not have a gender identity? What if we treated that? I don't know if that's true, but I think, you know, all that should be looked at and addressed and help people with whatever they're having trouble with. Anyone want to get mad at me for that? I'm just trying to get some reaction from you guys. No, I'm kidding. Anyway, I thought it was interesting to hear that opinion, and we can talk about it more when we're talking gender identity stuff. But now switching gears to burnout. I didn't want to just talk depression. I wanted to talk, oh my gosh, I took so long. Do you guys want to talk about burnout, or should we save this for another day? Let me just show you. Summer, do you have the case from last week?
Yep, I can share screen if you can.
Yeah, just a sec. Let me just show you guys some resources to look at, because the National Plan for Workforce Wellbeing, they've been working on it for a couple years now, and they have these nice resources. So you'll have this slide set, and let's see, National Academy of Medicine, and then this is the American Medical Association is also supporting. But let me show you, here we go here. Can you see National Plan for Workforce Wellbeing?
No, you might have to stop sharing and then reshare. Yeah.
Yes. So let me just show you this web page. There's my share. Because there are a lot of resources, and if people can take a look before next time. Can you see now National Plan for Health Workforce Wellbeing? Okay. Yeah. Okay, so they have all these areas, and you know, we've been told that burnout, oh, just do some self-help and just do yoga and just do relax, just meditate. Well, of course, that's not going to solve the problem. So I am really heartened by how they have all these different areas that they're looking into, and building positive work and learning environments, and measuring it, and stigma. And so they have all these different resources. Resources are down here. Okay, so there is a whole resource page. And if you guys could look, we'll let you know, we'll give you a couple weeks notice when we're going to talk about burnout. And then if you guys can look at this page and see if there's ideas we haven't used here, because some of our health systems are really good. They have a wellness officer, they have a wellness plan, they address this. Some of ours don't. So maybe there is some things we can do.